Welcome to my presentation on chiropractic and Ehlers-Danlos syndrome. I am Dr. Ryan Emmons. I have been a chiropractor for nearly 2 decades. I have a clinical focus on joint instability and joint hypermobility. I am trying to create a greater awareness on these topics. This awareness is intended to help practitioners identify these conditions and have clinical judgment on the care they provide. That is because there can be a degree of risk. Let's discuss. According to the Ehlers-Danlos Society website, the Ehlers-Danlos syndromes are a group of 13 heritable connective tissue disorders. These conditions are caused by genetic changes that affect connective tissue. Some features seen across all types of EDS include joint hypermobility, skin hyperextensibility, and tissue fragility. Note that joint hypermobility is a common feature. Joint hypermobility means that a person's joints have a greater range of motion than is expected or usual. Some people have joint hypermobility that does not cause them pain or issues. Joint hypermobility is observed throughout the body in most types of EDS, but it may be limited to the hands and feet in some types. Although joint hypermobility is observed across all types of EDS, not everyone with a type of EDS has joint hypermobility. On the outside, this might not seem like a big deal when adjusting joints. However, when it comes to the neck, there can be risk. This is mostly related to what we call high velocity, low amplitude adjusting, or the thrust adjusting. And this risk is only a consideration in relative risk and not an absolute risk and contraindication. As always, clinical judgment is vital. The risk does not have as much to do with general connective tissue, though ligament laxity is a notable factor that we must consider, and I'll be discussing this more in upcoming videos on upper cervical instability and modern joint instability. The risk that I am discussing here does have to do with the vascular system and structure specifically. So when it comes to EDS, 6 of the 13 types have associated vascular fragility, and these are those 6 types. The following information was presented by the Ehlers-Danlos Society Instagram account, which brought it to my attention and made me lead into this presentation. So, arterial aneurysm is associated with these 4 types of EDS. Arterial dissection is associated with some types of EDS, which for us, specifically in chiropractic, cervical artery dissections are of concerns. Arterial rupture is associated with these 2. Now, it doesn't mean that these types are common, but we need to be aware. Vascular fragility needs to have awareness, especially when providing treatment and performing chiropractic adjustments. Since we will not always know if a patient has EDS or even the type of EDS, it is important to have awareness and at least screen for a risk factor. And I suggest that screening for joint hypermobility can be beneficial for that reason. One easy guideline is the Bainton scoring system. It measures joint hypermobility on a 9-point scale, and it is quick and easy for us to conduct clinically. Now we're going to see here is that we're testing 5 joints, of course, bilaterally, but we're testing 5 joints. So that doesn't include everything, but it is a good screening tool. Okay, so what we have for A, we have the pinky finger, which mine cannot hyperextend. Okay, we have the thumb trying to pull it back to the wrist. Of course, I do not have joint hypermobility. I have severe joint instability, but those are 2 separate conversations. Even when we look at elbows, okay? The other 2 will be knees and spine. You can download this online off of the Ehlers-Danlos website, and you will find that when patients have hypermobility, you will find many of these positive, and you can use this scoring system. I know that some people with EDS will say, well, I don't have this positive. Well, as I mentioned, not everybody with EDS will have hypermobility. It is just one of those 3 very common symptoms. And yes, hypermobility can exist separate from EDS. This is termed generalized joint hypermobility, but how do we know if the person has EDS or generalized joint hypermobility? Well, unless you are versed in EDS and ask appropriate screening questions, or if the person has had genetic testing, then you don't know. So we use this as a guideline to proceed and treat with caution. So then what treatment options do we have? Well, we do have some. Joint mobilizations are gentle and can be performed. So in my clinic, I perform C1 adjustments on my EDS patients as it allows me to treat the upper cervical spine, which involves joint mobilization movements, and we can maintain a neutral spine. I also treat affected soft tissues of the neck, especially cervical spine joint capsules, as they can be pain structures. Since these are not muscular structures, it does not loosen or destabilize the neck while being able to provide relief. So for me, when I'm treating somebody with hypermobility, instability, I'm always trying to shift that patient towards stability, not loosening or instability. If anybody is interested in learning about C1 adjusting, you can visit my course platform at courses.clinicalupgrade.ca. I developed that to teach chiropractors, physiotherapists, osteopaths, and massage therapists how to perform C1 mobilizations to help with that correction. Exercises can be provided if there is intention to providing stability and neurological function to the surrounding muscles is restored. So remember that if, say, with a C1 misalignment, there will be a degree of nerve compromise and therefore muscle inhibition. And we need to address that so that we can make sure that any muscle that we are exercising has any chance, a full chance of being strengthened and no limitations. Lastly, as I mentioned, we must also account for the ligament laxity and joint instability alongside joint hypermobility. And I say alongside because there can be other causes to joint instability that I currently teach in my courses and that I treat in my practice. Just because you have EDS or joint hypermobility does not mean that that is causing the joint instability, and that is treatable. As I say, this can coexist with EDS, and joint instability is treatable. I'm going to be discussing this in my YouTube videos in weeks to come. There's too much depth definitely on this to discuss it today, but you can explore my comprehensive in-depth course on upper cervical instability at courses.clinicalupgrade.ca. It is definitely worthwhile, especially if you have EDS or joint hypermobility, because it is something you can do to aid in improving the overall status of the condition. If you want more understanding of EDS, I encourage you to explore the Ehlers-Danlos Society resources that I mentioned earlier, which were the website and the Instagram account. Though we cannot treat EDS directly, there is much that we can do to impact quality of life through gentle adjusting, soft tissue release, and exercises which can provide better stabilization. To reiterate, this discussion is meant to be a consideration. We need to use clinical judgment and caution. Thanks for listening.